I just learned something strange. In 1973, a psychologist named David Rosenhan published a study that shook the world of psychiatry. It began with a simple but disturbing question. If a sane person walked into a psychiatric hospital, would doctors recognize the deception? Would they know the person was pretending to hear a voice? Would the label of mental illness become so powerful that it distorts reality? Would everything after it be interpreted through that label? To test this, Rosenhan and several other people became what he called pseudo-patients. They were not seeking treatment in the ordinary sense. They were entering psychiatric hospitals as part of an experiment. Each pseudo-patient arrived at a hospital and reported hearing a voice. The voices were described with vague words like empty, hollow, or thud. Apart from one false symptom, they had to tell the truth about their lives. This included their background and personal history. Once admitted, they stopped pretending. They behaved normally. They spoke normally. They said the voices had gone away. They followed the rules of the institution. They waited to see if the staff would notice their lack of actual symptoms. They were not truly experiencing the symptoms that brought them there. But that is not what happened. According to Rosenhan's report, all of the pseudo-patients were admitted. Most were diagnosed with schizophrenia. One received a diagnosis of manic-depressive psychosis. Their hospital stays ranged from several days to over 7 weeks. The average stay was about 19 days. And when they were released, they were not simply declared sane. In most cases, they were discharged with a diagnosis of schizophrenia in remission. That phrase matters. It meant the hospital was not saying, "We were wrong." It was saying, "The illness is still there, but the symptoms are not currently visible." The label remained. This is the part of the study that still feels unsettling. Once diagnosed, their ordinary behavior was often seen as part of the illness. This misinterpretation affected their treatment. If they took notes, that could be seen as unusual or obsessive. If they waited quietly, that could be seen as withdrawal. If they expressed frustration, it could be viewed as a symptom. It was seen instead of a reasonable reaction to being trapped. The person disappeared behind the diagnosis. For the staff, the label created a frame. And once that frame was in place, every action seemed to confirm it. That is one of the most important ideas in Rosenhan's study. The problem was not only whether a diagnosis was correct or incorrect. The deeper problem was what a diagnosis could do once it was attached to a person. A label can organize information, but it can also distort it. It can help clinicians notice patterns, but it can also make them stop looking closely. Inside the hospitals, the pseudo-patients described an atmosphere where patients often felt invisible. Staff members were busy. Routines were strict. Interactions were limited. Inside the institution, people were treated less like individuals. They were viewed more like cases moving through a system. This did not mean every doctor or nurse was cruel. That would be too simple. Many were likely overworked, operating inside institutions that were already shaped by pressure, hierarchy, and routine. But that was part of the point. A system can become dehumanizing without every person being malicious. It only needs a powerful label and a rigid routine. Sometimes, too little time is given to see the person in front of you. This lack of attention can worsen dehumanization. The pseudo-patients also noticed something surprising. Other real patients sometimes suspected that they were not mentally ill. Some reportedly asked if they were journalists or professors. In other words, people who were themselves hospitalized sometimes recognized something that the professionals did not. That detail makes the story even sharper. Those with the least institutional authority often saw the situation more clearly. They had more insight than those with the most authority. Rosenhan's study was published under the title "On Being Sane in Insane Places." It became one of the most famous studies in psychology and psychiatry. The study was also highly controversial. Its message was provocative. Psychiatric diagnosis, at least in the conditions Rosenhan studied, could be unreliable. Once a person enters a psychiatric institution, they receive a label. This label can be hard to escape. It can follow them for a long time. But there is another careful point here. The study did not prove that mental illness is not real. It did not prove that psychiatric care is useless. It did not prove that every diagnosis is wrong. That would be a dangerous misunderstanding. Mental illness is real. Many people need treatment, support, medication, therapy, and protection. Psychiatric care can save lives. A diagnosis, when used carefully, can help someone understand their suffering and receive proper care. Rosenhan's challenge was more specific. He was asking whether professionals could always distinguish sanity from insanity in a hospital setting. He was asking whether labels could overpower observation. He was asking whether institutions could reduce complex human beings into categories. And those questions still matter. Because labels are not only used in hospitals. We use them everywhere. We call someone difficult, and then every disagreement becomes proof. We call someone lazy, and then every mistake becomes evidence. We call someone unstable, and then every emotional reaction becomes suspicious. We call someone smart, and then we excuse their arrogance. We call someone dangerous, and then we stop listening to their pain. A label can become a shortcut, and shortcuts are useful until they replace thinking. The danger is that once placed in a category, we may stop responding to their actions. We might ignore what they actually do. We begin responding to what we expect from the category. The person becomes less important than the story we have already built about them. This is known as labeling. In psychology and sociology, labeling shapes perceptions and treatment. It can even influence how people see themselves. A label does not merely describe reality. Sometimes it participates in creating reality. If enough people treat you as broken, that treatment can alter your experience of the world. You may move through life differently because of it. You may become defensive. You may become quiet. You may stop asking for help. You may begin to wonder whether the label is all anyone will ever see. This is why Rosenhan's study had such emotional force. The pseudo-patients entered the hospitals knowing they were part of an experiment. They had an identity outside the institution. They knew, at least in theory, that they would eventually leave. But real patients did not have that protection. For someone truly suffering, being reduced to a diagnosis can be heavy. This can make their already painful experience even more difficult. The person may need care, but they also need dignity. They may need treatment, but they also need to be believed as a human being. They may have symptoms, but they are not only symptoms. That distinction is everything. A diagnosis should be a tool, not a cage. It should help someone receive care, not erase the rest of their identity. Rosenhan's study also sparked criticism, debate, and later re-examination. Some researchers questioned parts of the study. They expressed concerns about data collection and the study's overall integrity. That controversy matters too, because science itself depends on scrutiny. But even with the debate, the central warning remains powerful. Be careful with labels. Be careful when a category starts doing too much work in your mind. Be careful when you stop observing and start assuming. Because the moment a label becomes stronger than the person, perception begins to fail. Imagine walking into a place where every ordinary action is interpreted against you. You write something down, and it becomes suspicious. You say you are fine, and it becomes denial. You ask to leave, and it becomes resistance. You become trapped in a system where insisting on your sanity may backfire. Your insistence can be interpreted as part of the problem. That is the nightmare at the center of Rosenhan's story. Not just being misunderstood. Being misunderstood by a system that has the power to define you. And this is why the study continues to disturb people decades later. It touches a fear almost everyone understands. The fear of not being seen accurately. The fear that someone will decide who you are before they truly listen. The fear that one label could swallow the complexity of your life. So the lesson is not that diagnosis should disappear. The lesson is that diagnosis requires humility. It requires evidence, context, listening, and revision. It requires professionals to ask not only, what category does this person fit, but also, what might I be missing? And outside the hospital, it asks the same of us. When we meet someone, do we see the person, or do we see the label first? Do we listen, or do we classify? Do we allow complexity in people's stories? Or do we confine them to the first narrative we hear? Rosenhan's experiment was about psychiatric hospitals, but its deeper question is much wider. How much of what we see is reality? And how much of it is the label we were already prepared to believe?